name is Dr. Samina Qureshi, and I'm an international medical officer with the MSSO. Today, my MSSO colleague, Nicole Fornerato, and I will be your instructors today. As well, Hannah Eaton is going to help facilitate the session. Nicole, would you like to introduce yourself?
Sure. Hello, everyone. My name is Nicole Fornerato, and I'm a clinical associate with the MSSO, coming to you today from Northern New Jersey.
Thank you, Nicole. So in order to be interactive with you, we are going to be using the Poll EV software, and at various points in the presentation, I'll prompt you to log in so that you can participate in the many coding exercise that we're going to do today together. I would like to point out that the Q&A session that we have dedicated for you is intended to answer questions around the specific principles and exercises that we discussed today, and it's not intended for general coding questions. For some of the more challenging coding scenarios that you encounter in your daily work sometimes, you will have an opportunity in the end of this presentation to submit those for possible inclusion in our next Let's Code Together session. So we do welcome tough, challenging scenarios that you really don't know how to approach for coding, and you can submit those towards the end. Today, I'm going to be using the web-based browser to perform exercises, and we have provided a temporary training password as well as a user ID for you to use. It's in the chat section of the control panel. So you can access that and log in using that, or log in using your own personal password and ID. Now, this session today is scheduled for 90 minutes, and in the unlikelihood that we don't finish, we will carry over those exercises that we don't get to in our next Let's Code Together session. Okay, next slide. Okay, so before we begin, and also for some of you who may have never attended any of our prior webinars, I would like to provide just a very general framework and a brief historical background on MEDRA. First of all, I want to let everyone know that MEDRA is an ICH initiative, and the ICH stands for the International Council for Harmonization. And MEDRA itself was started development around the mid-1990s. MEDRA is a living, breathing, and ever-evolving terminology. And of course, because of that, it does require constant maintenance. For that purpose, the ICH tasked the MSSO, or the MEDRA Support Services Organization, the job to maintain and support MEDRA. Now, this includes various things such as providing training, such as the one you're attending today, as well as administering licenses. Now, all of these MSSO activities are overseen by the ICH MEDRA Management Committee. And the MEDRA Management Committee is in turn composed of various industry and regulatory bodies across the ICH, with the WHO acting as an observer. Okay, and the next slide. Now here's a very verbose, lengthy disclaimer and copyright notice. So I won't read it as, per verbatim. I'll just try to summarize it as best as I can. So the very first bullet talks about that before we begin any presentation, we are required to read and review this notice. And MEDRA is owned by the ICH. All of the material that we present today is also copyrighted material and owned by the ICH. Now, aside from the logos that you'll see, all of the material that I present today can be used by you in your organization. But if you change or modify the material in any way, you must acknowledge those changes and in no way imply that those changes are supported by the ICH. And the second bullet is legal lingo, so I have to read it as such. This presentation is provided as is, without warranty of any kind, and in no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And thankfully, the third bullet is not relevant for us because it talks about third-party material, and our presentation today has no third-party material. Okay. Now, so first of all, let's talk about the audience participation expectations. So we do, we do encourage you to ask questions. After each exercise, I will pause and give you an opportunity to ask questions. And the way to do that is to write in your question in the Q&A panel in your GoToMeeting control panel. Now, in the interest of time, there might be some examples we disagree with. You may, very strongly feel that there should be another code as the answer. But at the outset, with the nature of coding and a presentation of this kind, we agree to disagree so that not all of the term selections are absolute correct choices. There may, in some instances, be another code that may just be as good. So specific coding requests cannot be taken during this session. Like you can't, like I said in the beginning, you can't give me a specific example and say, how would you code that, right? Your questions should revolve around those examples that we're discussing today. And of course, those very challenging scenarios that you sort of scratching your head on, you will have the opportunity to submit those in the end, and then we'll bring those examples and discuss those in our next Let's Code Together session. Okay. Now here, before we begin, we want to do a practice question with you all. So we're going to have you all log in. So I'd request everyone either use your computer browser, a tablet, or your phone, and go to this URL. Type in www.polev.com/NICOLEF or Nicole F. Nicole has been kind enough to lend us her PoleEV account. So I'm going to give a few minutes or a few seconds actually for everyone to log in. Once you're there with your iPhone or your smartphone, I should say, with your smartphone, show the camera this QR code and it'll automatically take you to the PoleEV app or the platform. So some of you who are using your computers, you can use this URL in blue. Others who are using a smartphone can use the QR code right here that's displayed now to log into Pole Everywhere. So let's let everyone log in. It's very simple. And then we will do a joint question. So once you've gotten there, the next step, you will see a screen. And let's go to the next slide. Okay, here's where you should be. You should see this question, where are you located? And on your, once you're in PoleEV, you can respond and let us know where you are joining us from. And it looks like we have lots of markers in the US, as well as we have some in India. We have lots and lots of people attending from Europe, various countries in Europe. Excellent, wonderful.
Yes, and Samina, this is my favorite slide of the whole presentation. See where we're all located and see all the different, the worldly view we'll get on all the questions.
We have people from today. Africa. Wow. Interesting.
Lots and lots of people. It looks like this is good.
Excellent. Well, welcome everyone. We're very happy to have you join us. And I know it's probably different time zones. So some of you will be bright and early like Nicole and me, or you'll be, it'll be towards the evening. So really appreciate your time and very encouraging to see this attendance. Someone's in the water. I see the balloon.
And it looks like everybody is able to use the Pole Everywhere tool, so that's good too. But look at all these people, Samina.
Yeah, it's very heartening. Excellent. So just like you logged in here for this one, similarly for the questions, the coding exercises, you'll do the same. You'll log in and then you'll be able to type and interact with us. Okay. So that was very successful, Nicole.
Okay, yeah, so very successful.
So now we know how to use the PoleEV platform. Now we're going to just show you how you can use the MSSO Medra browsers. Of course, some of you prefer, there are 3 options on using or accessing the Medra browser. You can use the Medra desktop browser. You can use the web-based browser, which is what we're going to be using today to demonstrate the exercises. And some of you may even prefer to use the mobile Medra browser. And these are all the 3 different options you have. And as I mentioned before, in the chat panel, we have given you a temporary username, as well as a temporary password to use in case you don't remember your own login ID for the browser. And of course, here is the temporary or the user training username we're giving you, 7001. And the password, as you can see, as well as the URL to how to get to the Medra web-based browser. Now, one other way this screenshot is showing you is you can also go to our website, which is www.medra.org, and Nicole is demonstrating that for us. You go to the website, and you go to medra.org, and all the way at the top, you see the acronym WBB. You click on that, and it directly takes you to Medra web-based browser. So that's another way to go to the web-based browser from the website. Okay. Now let's go and show you the next slide. Okay. So now we know how to get into POL-EV. We know how to access the Medra web-based browser in order to perform the coding exercises. Now let's discuss some of the common challenges we find when we do medical coding. First of all, you're going to find that not always, sometimes you do and it's very easy, but not always can you find an exact match in Medra to what is being reported in your verbatim. Okay, so it's not always available. So what you do is you do your best, you use your medical judgment to capture what is being reported, right? And you should have a mental decision tree in your mind when there's not an exact match. And of course, as I mentioned before, there may be more than one approach to capture certain concepts. And of course, a very good document for that, to give you all the options, is the Medra PTC, or Points to Consider document, which serves as a reference guide because it tells you how to approach various coding scenarios. It gives you a preferred option as well as an alternate option. Now, the way to access this Points to Consider document, for those of you who are not familiar, again, it's available from either the web-based browser or even from our Medra website. And maybe Nicole can show us either one of those, and I can show them how to access the PTC document. Okay, so if you go to the Medra browser, or if you can also use the Medra website, medra.org. Once you go there, there's a link to PTC. You can do that. Click on there, and it takes you to under the how to use Points to Consider document. There you go. It gives you a whole list of Point to Consider documents. And the one I'm talking about today that has to do with coding is the Medra Term Selection Points to Consider document. Okay, so that's how you access this guide that kind of gives you the various options to code. Okay, so let's go back to our slide on medical coding challenges. Now here, what also I want to show you is there are various ways people interpret the same data, right? I may see something in a report and think of it as reporting something else, versus Nicole may look at the same verbatim term and think something else. So how you interpret data should be consistent, and that's where coding guidelines come in. It sort of directs you, when you have a particular reported scenario, how to approach that consistently within the organization. And of course, a very important rule of thumb in coding is not to do assumptions, right? You should never assume what's being reported. You only code that information which is given to you. Don't add information, but by the same token, don't omit to capture what is being reported. And the overall summary for approaching coding challenges is to use your best medical judgment. Okay. So let's go to the next slide. And here we're showing you the QR code again, because we're going to get ready to approach our very first coding exercise in Let's Code Together. Okay, so let's go to the first exercise of the day. Okay, so here's in the blue box is what you get in a report, an example report verbatim. Our first example states the 10-year-old boy had segments of white skin patches on only one side of his body, diagnosed as possibly a type of vitiligo, which is segmented. He also had a runny nose and fever. So first of all, there's a lot of information there, right? I have to look little by little, each line by line, and try to analyze what exactly is being reported, right? And sometimes your verbatim reports aren't always very clear. So I have to say, is this clear enough to code? What exactly are they trying to tell me? And where anatomically are these things happening, right? Because I have to sort of make sense of what is being reported so that I can accurately look in my thoughts, where in MedDraw, which anatomical location, which sock will I be looking for this term. And of course, sometimes you have complex concepts that need to be split, right, with two terms. So in this case, again, let's read it again. The 10-year-old boy, so it's a 10-year-old, it's a young boy. He had segments of white skin patches on one side of his body. So they went to tell us that it's only one side of his body. But here they're also saying diagnosed as possibly. So this looks like a provisional diagnosis because it has that clue, possible. Diagnosed possibly as a type of vitiligo, which is segmented. He also had a runny nose and fever. So they gave us other signs and symptoms as well as a provisional diagnosis, which they think is vitiligo, which is segmented. Okay, so let's go to the next slide with that information. Now that you've all logged into POLL-EV, we're going to the first example. I would like you to type in what you think, how you would code all of the information that's given here. Of course, there's more than one code. So I'd like you to put in all the LLTs which you think can be used to code this particular scenario. Okay, people are good. There's some people are capturing runny nose. Okay, so some people are putting all their codes in one line. Someone said segmental vitiligo. Someone said vitiligo. Possible vitiligo. These have to be actual LLTs. So there's no code in MedDraw that's possible vitiligo. What exact LLTs would you write? So this person wrote segmental vitiligo, runny nose, fever. Some other people are writing in vitiligo. Fever, okay. Okay. Unilateral, okay. Very good. So Nicole, any observations in this exercise? What are you seeing a pattern?
I'm seeing a pattern of lots of people agreeing on runny nose and fever, and then there's a mix on the rest. So looks like,
right.
Yeah.
Exactly what I'm seeing. Okay, so let's move on. We kind of have a feel for what people are going to. These seem to be the most common choices.
Yeah, and we can always come back to this, Tamina, too, if you want to take a look in a little bit.
Sure. Okay, so now the way I would approach this is, now we saw people say segmental vitiligo, we saw people just write vitiligo. So when you're unsure, because obviously we may not be sure and familiar with all the diseases out there and all the descriptive things we find in the various verbatims that we encounter, you can always, and it's encouraged, to use a good medical reference to find out more information about a particular item. So here I have referenced vitiligo. I looked up in a good established medical reference on what is vitiligo. And here very briefly, I can just see at the outset that vitiligo can be classified into two primary types. There's a non-segmental and there's a segmental vitiligo, right? And then I read and I see what are the common gold standard signs and symptoms of this particular condition. And as I read, and I won't, for the interest of time, read everything, but I can surmise from here by this reference that I don't see runny nose or fever as part of the standard symptoms of vitiligo, right? And so it's very good that people did code that, right? They coded runny nose and fever separately. As well, this was a possible diagnosis, so it was a provisional diagnosis, and the PTC does tell us it's the preferred option for provisional diagnosis to code all signs and symptoms as well as the provisional diagnosis. So excellent job for those who picked runny nose and fever. As well, then we had a bit of a debate. Some people picked just vitiligo and some people picked segmental vitiligo. So I'll go to my browser and see what do I find with vitiligo. So in the Medra web-based browser, okay, let's see if I can type vitiligo, V-I-T-I. Yeah, if we, Nicole, if you could type in vitiligo, V-I-T-I. Okay. Because we have to make sure that the concepts that we put in the choices are actual LLTs, right? So is there under vitiligo, what do I have? Maybe V-I-T-I. V-I-T-I-L-I-G-O. Okay, good. So that's good. So there is a concept, specific LLT for simple vitiligo, but we also have a specific LLT for non-segmental vitiligo as well as segmental vitiligo. And our example showed us that it was a segmental vitiligo, right? And if you open it up, they go to the same PT, the base concept of vitiligo. Very good. We open up the PT of vitiligo and we see all the LLTs under it. Excellent. So here are all the LLT choices under the main PT vitiligo. But the most common thing that's advised is to try to match the exact verbatim with the most closely matching LLT. And the most closely matching LLT to the reported verbatim is the segmental vitiligo. So that would be the correct choice, LLT segmental vitiligo, because that's what's been reported, right? They gave you a specific type of diagnosis. And so you would choose that since you have an exact match LLT. Very good. So let's go to the next slide. Okay. And here again, just to reconfirm, I'm reading up and it says, what is segmental vitiligo? For my knowledge, it says it's usually in children, right? Around 3 to 10, and 3 to 10, with around 3 in 10 children developing this type. Okay, and what happens in this type? There's a loss of pigmentation, usually in a dermatomal pattern and affecting one side of the body. So this is actually the way it's described in our verbatim as well. So I'm again very happy with this term that I picked, segmental vitiligo. So the next slide. Okay, so let's go in Medra, and here is just a screen capture of the live search that we did with Nicole, exactly the way she did it. We went and looked at vitiligo. We found out that when you opened it, you had an exact match to the reported verbatim of LLT segmental vitiligo. Very good. And the final slide for this exercise shows you what the correct answers are: segmental vitiligo, runny nose, and fever. So I think everyone in the poll EV was correct. The only thing I would say is instead of picking just vitiligo, pick the specific type that they said in the verbatim string. Okay, excellent job. Very good. Okay, so let's go to our second example.
Should we ask for questions, Samina? Maybe pause and see if there are any questions associated with this one.
Do you see any in the chat?
Yes, we do have two, and they seem to be asking the same concept. They say, wouldn't you also code the skin decoloration, since that was the physical exam finding prompting the provisional diagnosis of vitiligo, or skin depigmentation, discoloration of the skin? Yeah, that's what they're curious about.
That's a very, very good question. And absolutely, that's also appropriate. If you had coded in addition white skin patches, you could do that because it's a provisional diagnosis. You could absolutely do that. So that's correct. Very good. More than one approach to approach a particular scenario. So excellent question, excellent observation. And you said that both were the same, right? Roughly the same.
Yeah, they were both asking about the need to code the
Mhm.
discoloration or the
Mhm.
depigmentation. So it looks like that is it for that example.
Yeah,
Thank you.
and Samina, if with that being said, that's a good example, right? I'm sure you would agree of how coding conventions can play a big role in this, depending on how you decide to handle these types of terms, right? If you go with the possibly, or if you first code what's exactly there and then try to get a definitive and things like that, right? So
Absolutely.
it's a good example for that as well.
It sort of drives home and the point that we definitely should have internal coding conventions so the whole team codes consistently with the same approach. Okay, so let's go to the second example. Okay, so here the verbatim is, after taking his medication, he noticed his tongue became enlarged, rash on his neck, and edema of hands and feet. Okay, so if we look at the verbatim, his tongue, the way they reported it, his tongue became enlarged, right? It became bigger, it became enlarged. And then a rash on his neck, edema of hands and feet. Okay, so let me go to my Medra browser. And let me put it in, because exactly the way they say, enlarged, his tongue got enlarged. So is there something in there for enlarged tongue? Enlarged tongue. Let's see, does anything come up? It doesn't come up. So then I'm thinking, well, let me just look up what do they have for tongue? What other things does the tongue have? If it doesn't have enlarged, maybe they express it in a different way, right? So what are the different things for tongue? Then I see that they have anesthesia tongue, they have biopsy tongue, you have investigative findings, you have descriptions of black hairy tongue, coated tongue. And as I look through, I don't really yet see any LLT that says that or sort of signifies a large tongue or a big tongue. Keep looking. We have paresthesia, plicated, tender, abscess. Nothing really goes to tongue. So what I'm trying to see is then maybe if I open up, let's say, if you open up tongue itching or tongue pain, any of those, and see what the HLT is. So maybe I'll look in the HLT. The HLT for, let's say, tongue pain is tongue signs and symptoms. So if you open up the HLT, you highlight it, right click, go to browser, and then on the left-hand side in the browser, we'll look at, so this is called a sort of a bottom-up search. We're looking at the broader HLT just to get a feel for what other types of tongue things can we find. Okay, so I see that under the tongue signs and symptoms, there's lots of things. They also refer to tongue as glossodynia. So something, the tongue is also referred to as glosso. It's also, let me use my Dorland's dictionary. So if we go to our next slide, it gives a little snapshot of Dorland's.
Would you like me to open the poll up in between, or you want to wait for the poll and then go?
Or let's see what they guess before I sort of lead them to the right answer. Let's see what they think. So everyone, please go into poll EV. Hopefully you're already in there, and go to the second exercise, which Nicole's going to open up. Okay, so let's see what people are saying. Swelling of tongue. So they're equating tongue became enlarged with swollen tongue. Neck rash, hand edema, feet edema. Okay, swelling of tongue. No, I don't think you can equate swelling with enlarged necessarily. Tongue inflammation, swelling of tongue. Okay, so most people are equating swelling and this allergic reaction. So Here I would say that you can't assume. Remember at the very beginning we said don't take away information from that which is reported. On the other hand, don't add information. Don't assume something that's not there. And for someone who picked rash, we have specific, they're saying where it is, rash on his neck. So you're right, the base term is a rash. Our primary objective is try to get as closely and as specific as possible as to what is being reported, if there is a term. Okay, so I see thick tongue. Okay. Okay, let's take on what someone said here. That's a neat new term that I see, macroglossia. So with that thought in mind, let's go to the next slide, macroglossia, because I saw some terms under the tongue disorders that were glosso. So tongue in the Latin root is referred to as glosso, right? So if we go in the browser and look up what someone had typed in the poll EV, we look up macroglossia. Glossia or gloss being the base term, Latin term for tongue. So if we go in the browser and look up macroglossia, but first we should see what it means in the Dorlands. Yeah, so macroglossia, if you look up in your established Dorland's Standard Medical Dictionary, it's defined as excessive size of the tongue, and that's what enlarged tongue is basically. It's increased size, excessive size of the tongue. So macroglossia is that term, because I didn't find tongue enlarged or tongue big. So is macroglossia in the browser? So let's search for that term, because that's what equates to. Okay, so when we look up macroglossia in the browser and we look up how it's linked, LLT macroglossia goes to PT macroglossia, which in turn is linked to 2 HLTs. And we see when we open those up to which SOCs they go to, it shows the primary SOC going to the congenital. So when a concept term is linked to the congenital SOC, it means the person was born with that particular disorder or that condition. In our verbatim string, he wasn't born with it. He took a certain drug and then he noticed that his tongue got big, right? So he wasn't born with a big tongue. So this, even though it matches macroglossia means enlarged or big tongue, that doesn't seem to be the correct thing because he wasn't born with it. So by the same token, I see other terms in MEDRA where the arrow is pointing. There's another type of macroglossia. There's acquired macroglossia. I think bingo. This is the correct term because he got the enlarged tongue after he took the drug. And this, when you look at the hierarchy using the browser, you see that the hierarchy for this particular LLT, acquired macroglossia, is GI, gastrointestinal disorders, whereas the plain unqualified macroglossia goes to the congenital SOC, which is incorrect because he wasn't born with it. So the take-home message here is sometimes it's very important when you pick a concept and you're not too familiar, make sure you look at the entire hierarchy of the term to make sure that you're actually capturing and intending to capture exactly that which has been reported, right? So this person got the enlarged tongue after he took a particular drug, right? He wasn't born with it. So the correct LLT would be acquired macroglossia, okay? So that's the solution for the person who picked macroglossia. It would be acquired macroglossia. So again, the take-home message is, if you're not too sure, confirm the definition of terms. As well as in the first example, if you're not too sure of a disorder or a condition, you can use a medical reference. And of course, always check the hierarchy of terms to make sure you're not picking a congenital term versus an existing term that is acquired. Okay. Now, for the other things that were reported in the verbatim, if we go to the next slide, we'll see here, someone picked rash, right? And my comment was, if you pick a particular concept, try to see if there's something more exact match to what is reported. specifically in that anatomic area. And here it was a neck rash. If you open up in the browser, the PT, and here I have a screenshot, the PT rash has lots and lots of LLTs of all over various areas, right? So if Nicole's going to do it live for us in the browser, if you take the PT rash, and if I highlight it, the plain term rash, or even you can just look for neck rash. Is there a term called neck rash or rash neck? And lo and behold, there is, and it resides under the PT rash. So instead of picking rash, it's not incorrect because that is the PT. You look for the LLT that is the exact match, and you do have something specifically for the neck under the PT rash. So LLT neck rash would be the correct choice, would be the best choice. Okay. So let's look at something else that was reported. Now they said that there was swelling of the feet. No, there was edema of the hands and feet. So edema of the hands as well as edema of the feet. Now, when we look up edema hand and edema feet, we see on the left-hand side, everything is opened up. There's an exact match of edema hands, and there's an exact match of edema feet all the way on the bottom. But both of those things are both linked to the PT peripheral edema, right? Edema feet for foot edema is to edema peripheral as well. So both hand edema, foot edema are linked under the PT edema peripheral. Now, our PTC document, again, I told you that that's the document that gives you a framework and a coding advice. What do you do in these scenarios? So if there's a term that will capture both, right? I could say edema feet, edema hands, but they both reside in the same PT edema peripheral. The best LLT to capture that would be edema extremities, right? Because your hands and feet are your extremities. So the LLT that would capture both would be edema extremities, because that's what hands and feet are, right? So instead of alone edema hand, edema foot, you would pick one LLT, edema extremities. And that again resides in the same PT edema peripheral. Okay, so if we go to the MEDRA term selection guide, that exactly I want to point everyone to this guide. If an event is reported to occur at more than one body site, right, exactly in our scenario, and if all of those LLTs link to the same PT, then select the LLT, the single LLT that most accurately reflects the event. Okay, and here they give you exactly the example that I had in my exercise, right? If it is reported that there was edema of hands and feet, the best LLT would be edema of extremities, because they all three link to the same PT, but this LLT, edema of extremities, most closely reflects what is being reported, because your hand and feet together are known as extremities. So that is the take-home message, again, established by the PTC as well. So this is what would be the best code. And if we go to the next slide, I think we have our correct answers. Now, are there any questions around this?
We have quite a few questions. Our first one asks, I apologize in advance for my pronunciation. Can we not code glossitis for swollen tongue?
So glossitis, you would not code because that's a diagnosis, right? And we cannot assume what he has, that he has inflammation. It doesn't say anywhere his tongue was inflamed. It just became enlarged. Yes, when you have swelling of the tongue, it's inflamed, but we don't necessarily know that's the basis of the enlargement of the tongue. So we wouldn't go and make a diagnosis. We would do exact close match. And the best one is macroglossia, which is defined as enlarged tongue. So good question.
Our next question asks, why is it coded as macro if we don't know the size, like macro being too big but just mildly swollen?
Because macro that's what it means. When we looked at the definition in the standard medical dictionary definition, it doesn't say 2, medium, extra large. There's no, size, the variety of sizes. It just means excessive than normal, right? Excessive size of the tongue. And therefore, the macroglossia is the best code.
Our next question asks, why is it not a tongue edema? Because enlargement happens because of edema only if it is a short timeline.
Again, edema is a diagnosis term, and tongue enlarged is sort of like a sign and symptom. Edema is a diagnosis. We cannot code for diagnoses that are not reported. But the converse is true. If you have a diagnosis, if it had said edema tongue, then we could code it. This is just a sign it became enlarged. We don't know if it was inflammation. We don't know if it was edema. We don't know if it was allergy. We just know it was large.
Our next question says, since macroglossia LLT has 2 different HLT, one to gastrointestinal disorders and the other one as congenital, the most suitable is acquired macroglossia, which leads to the SOC gastrointestinal. Also, acquired will be due to acquired will be due to it's the most specific. Is that correct?
Yes, the reason we didn't pick the plain macroglossia is because we found out when we drilled down and checked the hierarchy of the term that it is intended for someone who's born with a big tongue. That's their congenital issue or their characteristic. As they were born with a large tongue. In this case, this person took a drug. He wasn't always born with it. He had a normal tongue otherwise. But after taking this drug, his tongue then became enlarged. Therefore, the acquired macroglossia is only linked to tongue disorders and not the congenital SOC. So this is the correct one.
Our next one asks, sorry.
Go ahead.
Our next one asks, do you need a code for the medication causing these symptoms?
No, because usually the medication in the reports is in a separate field. You know that this XYZ medication was taken. So it's just saying that after his medication, this is what he found. These are all the things that happened to him.
Our next one says, our next user asks, edema, it is a symptom, not a diagnosis. Acquired macroglossia develops slowly.
It doesn't say, it just says after its temporal relationship. After taking his medication, his tongue became enlarged. So it doesn't, we remember in the first principle, we said we try to match the LLT that is the best, closest match to what is being reported, right? Nowhere does it say edema, right? Tongue became enlarged. Certainly in edema, the tongue also becomes enlarged. There are several, if you're allergic to something that you have an allergy, the tongue may become enlarged. But the exact match, tongue became enlarged, was not in MedDRA. So we used the Dorland Medical Dictionary to find a term that is equated with meaning tongue became enlarged. A descriptive term. Macroglossia means tongue enlarged. And then we didn't choose the macroglossia because due to the nature of the hierarchy, it led to a congenital error. So we took the qualified macroglossia, which was acquired macroglossia, as the correct term. So edema is not reported. The exact match or the best exact match is this LLT.
Our next question says, can you use more than one LLT to code serious adverse events? And how do you ensure that the number of SAEs of a trial is adequately represented if there are more LLTs than number of SAEs?
So that's something you have to account for because sometimes, a very good question, sometimes you have to use 2 codes, right? It's called combination coding to adequately express a single SAE, in order to accurately, code that or capture that concept, you have to use 2 LLTs. So you have to account for that in your coding conventions and your data analysis and retrieval conventions, that sometimes that scenario may happen.
Our next question asks, why extremities? Doesn't the term extremity mean the whole limb, since the scenario is talking only about hand and feet?
Well, in this scenario, you can say you can consider your hand is an extremity, your foot is an extremity. So it's loosely interpreted to mean as such. But again, for this particular example, you could have said peripheral edema. I mean, the PT, right? Edema peripheral. You could have said that as well. So this is just a matter of, this my choice, my leaning towards this term, your choice. If you had said LLT edema, LLT edema peripheral, that would be correct too.
What I think is our last question for this example says, how would you code enlarged tongue in older versions of Medra? The different microglossia only became available in version 29.0.
And I think that that's exactly why there was a people said, well, we have a missing concept, and exactly for this scenario, what do you do when you have that scenario? When it's not born with it, he acquires it, what do you do? So acquired macroglossia, they're saying, got entered in 29.0. So let's see the history. You highlight it, you go to history. It was added in 9.0. So it's been there since version 9.0. Then you would have not been able to use just macroglossia, because that would be saying that he was born with it. That would be the incorrect term to use. Okay, any other questions? This is good. This is excellent. This is how you learn, by this interaction.
And Samina, it's another good example.
We did have someone say, I would not have thought about acquired macroglossia. Thank you for the example. So this was good. This was a good one.
Yeah, it's a stumper. I'm sorry, Nicole, you were saying something?
No, I was just saying it's another good example. I mean, this was very good that there was so much action around this term, and back and forth and going through the thought process, because it's also an example of, keeping consistency. And again, everything kind of goes back to coding conventions, right? The way you want to handle certain terms, or making sure everyone's consistent, whether it be with edema extremities or peripheral, et cetera, right? So it's another great example you gave of that taking precedence as well.
Yeah, the take-home message also is, as in the macroglossia example, is that had we not checked the hierarchy, even I would have said, okay, macroglossia, exact fit, let's move on. But if we check the hierarchy, that would have been signaling something wrong, that he was born with a big tongue, and that's not the case. It only happened after he took a medication. Right? Yeah. So that's why there's several things illustrated in this example. First of all, there's different ways to interpret, like someone would pick edema extremity, someone would pick edema peripheral, right? There's a choice the way you would interpret extremity. Then there's the picking the right term after verifying its hierarchy in Medra, making sure it's not connected to congenital, or making sure it's exactly the medical concept that you're intending to capture. And the neck rash, you would be perfectly right to just choose rash because it's the PT. But when you look under the PT, there's lots of specific anatomical areas of rash under that PT, and the optimal coding is exact match. And so if you have a term neck rash, you should pick that. It's very specific. It gives you where the rash is, right? If you just pick the PT rash, it's not very specific. So pick the closest match LLT to that which is reported, and don't don't assume things like I can't assume it's an edema tongue. Don't also assume. So do report that which is given in the verbatim.
Yep.
Okay, so are we ready to move on to the third example?
Yeah, and I was just going to say, make the browser your best friend, right, Samina?
Yes. Yeah, it lets you become familiar. The more and more you become familiar with Medra, the more and more you become familiar how the various functionings of the browser are, it can actually help you find a term when you're not sure. Okay, so let's move on to our third example. She complained of chills, nausea, vomiting, and intense flank pain. So she had a lot. She wasn't having a good day. The doctor said it was a kidney infection. with labs showing infection with Klebsiella from use of a device. So she had all these signs and symptoms. Then the diagnosis, the doctor said it was X, which is a diagnosis. It was a kidney infection with labs showing infection with Klebsiella from use of a device. So again, what is our mental decision tree or thought process going to be? First of all, is this clear enough to code? What exactly are they reporting? So they're, first of all, they start off with a patient complaining of several signs and symptoms, then the physician giving a diagnosis. So, right, this is the way you think. Something's a sign and symptom, something is a diagnosis. And what is the anatomical site? So it's a kidney infection. And then your thought process goes to, okay, where would I look for this specific match LLT for all the things that I need to code? And sometimes there's some concept that might not be able to be addressed with just one term, right? That's where combination coding comes in. And someone had a very intelligent, very good question before this on what do you do when you have a certain number of SAE, but you have more LLTs to report that. And that's where, again, my answer was make sure you account for that in your coding conventions, the combination coding aspect. Okay, so let's go to the browser and see how people would code all of this information that's in this example.
Would you like me to open the
poll EV? Yes, please.
Pull up first and then the browser, I guess.
Yes. I'm sorry, I meant the poll.
Okay, no problem. Just give me bear with me 1 second. I have to go in and out of here, so. Okay.
There we go. Here it is. She complained of chills, nausea, vomiting, and intense flank pain. The doctor said it was a kidney infection, with labs showing infection with Klebsiella from use of a device. Okay, some people are doing the chills, nausea, vomiting, flank pain, so they're capturing all the signs and symptoms. Okay, some people have kidney infection, some said device-related infection. Okay, I'm seeing all kinds of things. Okay, someone said Klebsiella urinary tract infection. Again, I would say, well, does it say anywhere that it was a urinary tract infection? We don't add information, we don't subtract information, right? Okay. Kidney infection, some people are doing exact match, right? That's our goal. We use our medical judgment because we try to do exact match, and we also try to capture everything that is being reported and not subtract anything. Okay, bacteremia, I didn't see anywhere where it said bacteremia, but they did capture the bug, the organism Klebsiella. Okay, so Klebsiella infection, someone has. Kidney infection. Okay, someone is doing combination coding, good. Device-related infection, good. Someone has all the signs and symptoms. I must say that do not hesitate to put in an answer. This is all anonymous. We don't know who's answering from where, or we have no idea. We just see answers. So be brave. We won't know who's answering a wrong answer or a right answer for that matter. So don't hesitate to use the poll EV. Okay, so someone did write kidney infection plus Klebsiella infection. Okay. Okay, so I think let's go into the browser. And let's see. So do we, our primary goal should be to look for what is reported. Kidney infection. So put in Klebsiella kidney. Is there anything that has the specific organism with the infection? There's no term that has Klebsiella and kidney in there. Okay, so maybe sometimes, you know, they use kidney and renal are synonyms. Is there a Klebsiella renal infection maybe? Because those are kidney and renal are interchangeable. And there's nothing coming up for that either. So what I'm going to have to do, if you look up renal infection in the browser, okay, and if I open that up to the PT, it just says kidney infection, right? And we already searched, there's no Klebsiella. But let's just see what's all the ILTs under the PT kidney infection. Okay, and then we see under the PT kidney infection, we have the chronicity, we have chronic kidney infection, we have acute kidney infection, but of course, there's nothing that has the organism with it. And if you just generally look under that HLT, what are the other PTs we see? If you just scroll up and down a little bit, yeah. So under urinary tract, you have genitourinary tract infection, you have our plain PT kidney infection, you have pyelonephritis, you have acute, no. So I don't see Klebsiella specifically in here. Okay. All right, so what we're going to have to do is we're going to have to do our combination coding. But let's read a little bit about kidney infection. In the next slide, I checked my reference. So I wanted to read what are some of the gold standard signs and symptoms and find a little information about kidney infection. So symptoms of kidney infection begin suddenly with chills, fever, pain, nausea, vomiting, right? Okay. So those are basically what our person had. He had fever, chills, pain, and flank pain. Okay, so I got a general idea what kidney infection looks like as far as in signs and symptoms. So let's go to the next slide. Now here we're in a conundrum because we can't find the exact organism with kidney infection, right? So the MEDRA term selection points to consider document, which I said is the guide that gives lots and lots of guidance on how to code. What do you do when there's no available MEDRA term that has both the microorganism, in our case Klebsiella, and the anatomic location? Well, the preferred option is to select a term that has both, but we don't have that. So alternatively, select a term that has the anatomic location and select a term with a microorganism specific infection, right? So what we're going to do is I want to definitely capture that it's a kidney infection, but I also want to capture the Klebsiella. So what I'm going to do is I'm going to do Klebsiella infection as well as kidney infection. So let's see. We did find the term kidney, so let's see if we have something for Klebsiella. So for Klebsiella, we have Klebsiella infection, we have a Klebsiella urinary tract infection, and I saw someone had picked that, but we can't pick that because our reported is a kidney infection. You're very right that most often UTIs lead to kidney infections, but that's not what's reported, right? Our report says kidney infection, although sometimes a causative reason is a UTI, you know, going up to the kidney and leading in turn to a kidney infection. So that would be incorrect because that's not exactly what's reported. So we do have the term Klebsiella infection. So I'm going to have to do this with an approach of combination coding. So I would pick the term Klebsiella infection and I would pick the term kidney infection. As well, I would not pick all the signs and symptoms because the preferred option for signs and symptoms and a diagnosis, the preferred option is to just do the diagnosis. But alternate option for those of you who did pick it is you can also pick the diagnosis as well as all the signs and symptoms. So if you want to take that approach and that's what your organization does, you can certainly do that as well. Okay, so let's see on the other next slide. So we solved the Klebsiella infection, we solved the kidney infection, and the doctor also said it was through the use of a device that he got that infection. So I'm very proud of and very happy that a lot of you did pick device-related infection. You didn't ignore that aspect. So you took that bit of information that was in the verbatim and you very correctly picked device-related infection. So very good. You got everything that was reported. So with that, let's go to the next slide and see the final answers. The final answers for this particular, the way I would approach it is to capture the kidney infection, the Klebsiella infection with the organism, and the device-related infection. I would take the preferred approach of not coding the gold standard signs and symptoms of the diagnosis, and therefore I would not code the chills, the nausea, the vomiting, and the flank pain. But you could, because that's also an alternative approach, it would not be wrong if you did code the signs and symptoms. So with that, do we have any questions for this particular example?
We do. Our first one asks, if Klebsiella nephritis existed in Medra, could we use that?
No, because that is a separate PT, nephritis. This is kidney infection. So you could not use that.
Our next one asks, do we code suspected transmission of infectious agents as special situation?
You wouldn't use suspected because here it's confirmed by the physician that it was indeed due to use of a device. So there's no suspected because it's confirmed.
This one is similar. In which situation should suspected off-label coding be used, or off-label coding?
Now that is a whole different discussion, and that we can answer either in the help desk, or we can use that as an example. In the end, we'll give you time to type in very challenging scenarios. You can use that in the end to type in. That's not related here, the off-label.
And it looks like that was our last question on this example.
Okay, so let's see. I'm thinking, Nicole, is there any other take-home message you think we should give here?
I think you covered everything. It's all the symptoms, but you have a diagnosis and you have definitive, so suspected wouldn't come into play, and you captured the use of the device and everything. So I think you did a very good job. I mean, I know you did a great job with the overview on this. So I'm happy with everything, but.
Okay, and the reason we didn't use UTI, urinary tract infection, because that leads to kidney infection. Again, I want to emphasize, and that's not what's reported here, right? Someone said nephritis. Nephritis is an altogether different diagnosis, so that's not what's reported, so we can't assume. Therefore, we only can report or code kidney infection. Now let's see what else someone said. So device, that was correct, device-related infection. Nephritis is a different diagnosis. We wouldn't use nephritis. Here someone got everything. So whoever answered this, too bad we can't give you credit because it's anonymous, but this was very good. Some people did get perfect answers. Very good. Okay, so I think we're ready. Go ahead.
Oh, I'm sorry. 2 more questions just came in. Someone wrote, in this case, since Klebsiella urinary tract infection is a diagnosis, and as per narrative is indicated that in the labs test performed, we have the agent of the kidney infection, I got confused why we separate the event.
Okay, no worries. Yeah, the take-home message is code as reported. So no worries. This is exactly teaching moments, and the optimal way to code is this.
And then our last question says, are you duplicating the reporting by including device AE and infection AE?
No, because this is a different PT. It goes to a different PT, so you're not duplicating. You're adding information to the report as to the source of the infection. Okay.
Yes, and in this case, right, I was going to say, in this case, if you miss one and you only capture and code one as opposed to like just kidney infection, then you miss altogether that it was device related, right? So you want to kind of hone in on both of those and make sure you have that available for the analysis portion of medical coding,
Correct.
which comes after this piece. So very important to have both.
Okay, so with that, I think we're ready to go to the next example.
Okay, thank you, Samina. Very good. Great, great back and forth and lots of explanations. So that was great. So with that, we'll move on to example 4. So this is my first example, and it is the patient had abnormal lab values, including glucose above reference range, cholesterol above reference range, hemoglobin above reference range, and blood pressure below reference range. So with that being said, when you get a kind of a report like this with lots and lots of information, especially lots of lab values, you have to think to yourself, is this clear? What's being reported here? Is there, we don't have to really worry about an anatomical site in this case, but what would be the most appropriate LLT or LLTs to use? And do we need to split such a term? Like, how do we even begin to capture and code a term like this? So first thing we do is let's break down the term, right? So we know that in here, the patient had abnormal lab values. Now we can kind of take that and say, okay, we don't need to worry about coding an abnormal lab value because we actually have the abnormal labs listed out, right? So the first one would be we have glucose above reference range, right? Next, we know we have cholesterol above reference range, right? So we're kind of breaking it down into pieces of how we would want to capture and kind of code a reported term that would come in like this. Next, we have hemoglobin above reference range. And then finally, as mentioned, we have blood pressure below reference range, right? So that's the only one listed there that's below when all the rest are above. So just something to keep in mind. But that's also kind of how when I receive a term like that, this is kind of exactly how my mind thinks to break down the term. So you get to see what's happening kind of in my mind as we receive a term like that. So what we'll do now is we'll go to our poll because I would like to see, okay, how would everyone code these terms, right? So we have the terms broken down. So we know we need a code for each of these. So we have glucose above reference range, we have cholesterol above reference range, we have hemoglobin above reference range, and we have blood pressure below reference range. So list all the LLTs, I mean, that you think would come into play here. And we'll give you a little bit of time to do that. So I see here, there's lots of different choices, and then polycythemia, interesting, blood pressure reading low. Okay, we'll give some time to go through. Remember, in Poll Everywhere, if you would like, you can insert more than one LLT at a time as well. And I know it takes a minute to go through the browser, so. So here's an interesting one. So we're getting lots of different responses, which is good. It's showing, you know, everyone's thinking about this type of term. But we have one here that states they would query diagnosis for individual markers with the trial prior to coding. Okay, so interesting approach. I'm going to give a little more time. So here we also have a different approach where it's hyperglycemia, hypercholesterolemia, polycythemia, and hypotension. Okay. Let's see what others are saying. Samina, do you see any trends that you wanted to pull out that I may be missing, or? All right. Give a couple more seconds. Just make sure people have enough time to enter what they feel before we start to go through this type of term. For our conventions. Okay, so this is probably somebody's internal conventions, which is always nice to hear about as well, how users are actually handling this. Looks like they would code to all abnormal type terms. Very interesting. Cholesterol, glucose, hemoglobin, and blood pressure. Okay, so also an interesting approach. All right, so in interest of time, I'm going to come out of this. I'll leave it open so you can continue to enter what you think would be the correct responses. And I'm going to move on. Okay, so what I did here was I added some thinking points around this type of term, because as you can see, we got many, many different responses, many, many different ways of handling it. We even got someone who, that was very nice, provided their approach internally, what's in their conventions. And that would be kind of the first thing I think to myself, does your organization capture and code investigation terms, right? First of all, starting out, some organizations choose not to capture investigation terms, right? So here I just put a little helpful hint. Maybe it's consider maybe within the organization, if you don't currently capture and code investigation terms, maybe it's something you can consider moving forward, something you could put in your coding conventions, right? Consider collecting and coding these types of terms if not already done. Also in this example, I used above and below within the reported term. Say, we could say that is what was received, right? So above and below were used within the term, and they are typically associated with a high or low value, right? Above meaning high, below meaning low, right? Not necessarily increased, decreased, but a high or low value. So how does your, just something to keep in mind again, how does your organization interpret above as, does your organization interpret above as high or increased, same with below or decreased? So these are just things to think about. Maybe things that you can in the future build a convention around if you don't already have one, right? Also, if a lab value is received, is it that's supposed to say is it, not it is, automatically queried to determine if a medical condition is present and should be reported instead. So we did see within the poll everywhere responses that someone did say that their organization opts to query these types of terms. Now, being, you know, a past industry person, I know that there are many different approaches to this, and this is something that each organization specific to itself kind of makes a determination on, right? So again, another point where maybe this is a great example where you can build a coding convention around. If you receive a lab value, is it automatically queried to see if there's some sort of diagnosis attached with it, or is it received at face value and kind of just coded as is, right? Not saying either way is right or wrong, just saying these are things to think about. So decreased and increased can vary depending on baseline, right? Another thing just to think about, a term can be high, but can still be decreased, right? Depending on its baseline value. So you can have a glucose reading that is high, right? It's above what it should be. However, maybe from the baseline, when they first got a glucose reading, it was super high, and now it dropped down, but it's still considered a high value. Just things to think about, right, as you're going through, and how you kind of would like to handle these moving forward, kind of things your organization can think about and maybe put conventions around, right? Another thinking point, when multiple lab values are received together, does your organization query a split? And I say in the clinical environment because in the clinical environment, terms like this should always be queried, right? We should not be touching any information attached to a term in the clinical environment. So if you were to receive a term with multiple lab values all in the term itself, maybe something to think about is you need to write a convention to kind of query to split these terms and enter these terms as individual terms. Say in the safety environment, there's a little more leeway, right? You're pulling from a narrative. You're pulling from a case. These terms are getting entered slightly differently. In that environment, maybe there is a way, you know, you can, in your system, you can enter these and just make sure that there's a convention around making sure that they're all entered and they're all in there so they all can be coded, right? And a recommendation would be, again, maybe you have a coding convention that you can put in place. And then typically having a high value does not change the coding, as it's associated with an increased PT in the Medra dictionary, right? So this is also something to keep in mind. So having a high value typically doesn't change the coding too much, because it does go to an increased type term. So whether you choose higher, increased, whether you choose higher, increased, it might not make a tremendous difference, but we do have one exception to this, and it is blood pressure high, right? So if you're coding to the LLT blood pressure high or blood pressure low, this is an exception, which I'll get to in the next slide. And down here on this slide, I just put, if you make a note of it, if you're going through and you say, oh, this is something maybe my organization needs to look at, I put this section here from the points to consider, 3.14. You can find information around these types of terms, so you can always go back and reference that. Now, what I'm going to do real quick is I'm going to go in the browser, and I'm just going to search a couple of these terms, right? So we'll just go in and we'll search glucose increased. So here we'll see, or glucose high I should have done, according to the example. So we'll go in and we'll say, okay, glucose high. As mentioned, it goes to blood glucose increased. So yeah, I mean, we could say above high, still goes to be increased, right? Next, we'll go to, say, cholesterol high, and we'll just see how this turns out. You could see here the PT, again, blood cholesterol increased. Now, when I go to blood pressure high, just so you are aware, here, slightly different. It goes to the hypertension PT, which goes out of the investigation SOC and into the vascular disorder SOC. But then you see here below, we have a blood pressure reading high. And in that case, this does indeed go to blood pressure increased, which then goes to the investigation SOC. So something to keep in mind when you're looking for terms to code to, because in a lot of cases, you know, you might say, okay, I'm just going to go to blood pressure high, and then it would go into the hypertension. So again, if your organization opts to say blood pressure high, okay, we're going to always interpret that as hypertension. That is what you would choose. If you say, okay, we're not going to interpret that as hypertension, we have another term available as blood pressure reading high, right? So let's use that as we go through. Here, I just provided an example. You can make a note of this in section 6.13, and this comes from the introductory guide to Medra, conventions and exceptions. So here you could see we have exact wording around this exception to kind of the investigation terms on with blood pressure in here. And what I meant to say at the start, and I think, I don't remember if Samina said it or not, what we both meant to say is that these slides are not available. So if you want, like how I have references here to things, you can mark it down, jot it down for yourself, but also you can go back, and this presentation will be available on YouTube, and you could kind of listen through it again, and you'll see the slides that were, everything I'm doing right now will come on the YouTube recording of this, and you can see, and you can also scroll through it to get to certain pieces if you just want to watch again certain pieces. So just something to keep in mind, because I do have screenshots, and so did Samina, of guidance and where you can kind of reference things in our documents that we provide for Medra. So again, high and low here are linked to the PT hyper and hypotension in vascular disorders, which we saw. So final suggestions here. Glucose above reference range. Of course, we would go to glucose high, right? Blood glucose increased. Cholesterol, we would go to cholesterol high, blood cholesterol increased. Hemoglobin above reference range, hemoglobin high, right? We have one available, goes to the PT of hemoglobin increased. And blood pressure below reference range, blood pressure low, which would go to hypotension. And again, I put that there as an example because typically blood pressure low would link to a hypotension. Again, we have options, and the reason why I went through the guidance and to show you is because maybe your organization, I put high here, but even if this was a low blood pressure reading low, it would go to blood pressure reading decreased. So you have options around that, and that's something that the main takeaway from this example, right? First of all, we want to take away that there are lots of times lab terms are kind of all piled together and reported as one. And it's a good idea to get into the habit of kind of splitting those. Also to think about, do we want to really capture and code these? Do we always want to query for kind of a diagnosis that may be related to a lab event? Are we doing that? Or a history of a diagnosis? If someone's having a glucose high reading, did they have a history of diabetes? Something like that. That's an organization specific thing to kind of think about. And then also here, options around blood pressure terms, and meaning blood pressure low and blood pressure high type term, or blood pressure reading low or high type terms. So just things to keep in mind kind of as we go through. So with that being said, Hannah, do we have any questions around this example?
We do. So our first question says, the way this is reported, I would stick to terms from the investigations, i.e. not create diagnosis.
Yes, and that's what that's because there were a couple answers that did come through on Poll Everywhere that did, provide a diagnosis instead of the lab value. So that's a very good observation to make. And again, very organization specific. So if you don't have a convention in place, I would highly, highly recommend this is one of the areas that you spend some time and create really solid conventions around it. Any more questions?
Our next question says, why this is an exception, coding BP low mapping to hypotension is like making a diagnosis. When they report BP low, they could only in single BP test low, and it is not aligned for other tests like blood glucose low mapping, which does not map diabetes.
Yes, and that's why we have guidance around it in our documentation. So you can see here, it is an exception because in layman type terms, typically that's how it's interpreted. So that's how in MedDRA we interpret it. So you can go through and kind of read through the guidance. And that's why I pulled it out as an exception, because it is an exception to the rule. And that's why it's listed here as well. And you can read about that in your introductory guide. Okay, any other questions?
Our next one says, why not high cholesterol?
Cholesterol high, oh, you could do high cholesterol or cholesterol high. I mean, same type of thing. So.
Wonderful. Our next one says, low blood pressure doesn't always mean hypotension.
Yes, so that's why we also have a term available of the blood pressure reading. So if we go here and we do low, right, we have the blood pressure reading low. And that's why I just pointed out for the final suggestion, I included the exception to the rule as one way you can interpret it. However, we do have this blood pressure reading low LLT available that you can most certainly use in code to and then query to see if it's a hypotension. I was just showing you here that if you strictly go to blood pressure low, which is what the term, it's closer matched to the exact verbiage in the term, then it will link to a hypotension type term. And that is an exception to the rule in MedDRA for how we handle that type of term. So I just wanted to kind of point it out to everyone, and then you take that back to your organization and kind of make a determination on how you would want to code that. Any other questions?
Perfect. I am not seeing any other questions on this one.
Perfect. So with the interest of time, we have about 7 minutes left. So because of all the great discussion today, which is exactly what Samina and I like, what we want, this was wonderful. I think it's great that you had Samina for the first part of the class going through all these examples and actually being able to tell you how she goes through. But with that, kind of, we got through 4 examples today instead of 6. So I have 2 others that we will roll over into the next Let's Code Together class. So don't fret. We will get to them eventually. But with interest of time, because I'm just going to scroll through these, you will see them at the next Let's Code Together. There's 2 more. But with the interest of time, we want to make sure we have enough time to get future feedback from you all. So I'm going to go into my Poll Everywhere, and I'm going to open up the feedback and future suggestions. We would like to hear from you. This is very important part of our also our class to see what are your current pain points. Is there anything that you would like us to talk about in future Let's Code Together? So my 2 examples, like I said, we will be doing next time. It's great that we can we're on a webinar right now, but I felt like I was in a room with all of you, and I'm sure Samina did as well today, from all over the world with all different perspectives. So I think this is fantastic, right? To me, it's such an honor to be able to do this, and it's such a way to actually, we can get our thinking, how we think and why certain things are. So if you have any other future suggestions, please let us know. Again, like I said, there was so much great discussion today. I'm going to keep this poll open. So please, 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 I know there are a lot of people online today. Definitely give us more suggestions, feedback, if you want to see this, moving forward, examples, etc. And I'm just going to take a moment because in November of 2025, I just want to let everyone know, the MSSO initiated a survey on in-person training, right? We were seeking user feedback on communication of training content, locations. So far to date, over 400 users worldwide responded to the survey. We have a link to the survey. Maybe Hannah, I don't know if you could provide this in the chat, the link to the survey, and a QR
Absolutely.
code that maybe you can also use when you're done putting the feedback in, because of course we want feedback. But Hannah will send you the link so you'll have it even after we close out this webinar. But if you don't mind providing feedback around, I know we have people from all over the world, but especially, Samina and I are based in the US, and we like to, figure out where we're going to do face-to-face training, or, just hear from our users what you want, what you would like to see, where you would want to see us. So if you wouldn't mind, in addition to providing us the feedback on that slide, in the poll everywhere I gave, you don't mind doing this, it would be greatly appreciated. And one last thing I want to say before we begin to close out this webinar is that Samina will be leading a Coding with Medra face-to-face class in King of Prussia, PA, the day after the user group meeting in June of this year. So that's King of Prussia is outside Philadelphia. We're having our US user group meeting in Philadelphia, the 11th of June. And Samina will be leading a Coding with Medra face-to-face class on the Friday following, which is June 12th, I believe. Hannah, you could correct me, or Samina.
Correct.
It's June 12th.
June 12th.
Yes.
June 12th. So Samina, I know, right, Samina? You would love to see as many people there as possible. And just maybe, we can't make promises, but maybe I will make an appearance as well, just for support in the background, and we'll be there, maybe the 2 of us, so you can come and introduce yourself and get to know us and meet us. Or Samina for sure will be there leading the class and going through examples and doing a whole day of coding, which is phenomenal. And Samina, I know you're looking forward to that, right?
Absolutely, yeah. I encourage everyone who can physically come to the Medra MSSO user group meeting on June 11 to attend. As well, the following day, as Nicole mentioned, on June 12, we'll have an all-day face-to-face training on coding basics, or coding with Medra.
Yep. It'd be nice to get to see a lot of you. So, and then just to wrap things up, we do have some contact info. We went on the Medra.org site today. You can find all of this info on Medra.org as well. It's just links to all the stuff, and then MSSO YouTube channel. If you don't have time to write down this link, you can just Google MSSO YouTube and it will pop up, and then you can search for any of these Let's Code Togethers. There's lots of them done all over the world as well, in different time zones and different examples you can look for. So with that being said, I'm just going to pull this up. Okay, we did get some examples, Samina. So I will take note of this. And oh, they want us to come to Europe, Samina. Yeah, we do have some people doing in Europe, but yeah, maybe one day, right? But we do have some people there in Europe to also that do these types of classes. But so this is great. So we will use these examples. We will use this feedback moving forward. I will do my 2 examples that I have rolled over from this class next time. And with that being said, we just want to thank you all. We know how busy everyone is, especially In this day and age, we're all wearing multiple hats, right? Doing many, many things. So we know that taking an hour and a half out of your day is a big privilege, and we appreciate it. And we thank you for joining and for having such an active and lively discussion today with lots and lots of questions, which were really appreciated. And I'm sure Samina will also say the same, right? So.
Yeah, absolutely. Really appreciate everyone, especially our global attendance from all time zones. So really appreciate those very intelligent, very good, strong questions. Thank you so much, and lovely seeing lots of right answers as well. So thank you so much for joining us today. We look forward to the next time where we take this input and these suggestions and incorporate them into our next training.
Yes, and we love having a global audience. And today I was told, I can't really see numbers, but we have a very large audience. So that also made our hearts very happy. So with that being said, we just want to thank everyone. We wish you a great rest of your week. And we hope to see you maybe down in Philly, maybe some other time face-to-face, or on a future webinar coming soon. So thank you all. Have a great rest of your week. Bye-bye.